Hello students, welcome to NCLEX practice class. In this class, we are going to see some important questions regarding NCLEX. So let's start with the question number 1. When assessing a child, which finding would indicate the presence of Kernick sign? Option number 1, calf pain when the foot is dorsiflexed. Option 2, pain when the chin is pulled down to the chest. Option number 3, the inability of the child to extend the legs fully when lying supine. Option number 4, the flexion of the hips when the neck is flexed from a lying position. So in this question, we have to find that what is the feature of Kernick sign. Okay, so Kernick sign is feature of meningitis. Meningitis is a condition in which there is inflammation of brain covering. So when there will be inflammation of the brain covering, the nerve passing from that area will be irritated. So physician do this procedure, do this assessment to check irritation of nerve. So let's find out the answer. So the answer is option number 3, the inability of a child to extend the leg fully when lying supine. Okay, so in Kernick sign, physician will tell patient to lie in supine position. Then he will tell the child to flex his hips at 90-degree angle and legs will be extended slowly towards the ceiling. Okay, so legs will be extended from 90-degree to above angle toward the ceiling direction. So when the physician will do so, child will feel stiffness and pain in his leg area. So this will indicate positive Kernick sign. Now let's talk about other options. First option is calf pain when the foot is dorsiflexed. So this is Homan sign. When there is calf pain, when foot is dorsiflexed, there will be Homan sign. Pain when the chin is pulled down to chest, this is a sign of knuckle rigidity. So when we will ask child to touch his chin toward the chest, so patient will feel pain in his neck region. This will be known as knuckle rigidity. Option number 4 says that flexion of hips when the neck is flexed from a lying position. Okay. So when neck is flexed in lying position, there will be automatic flexion of hips. This is Brudzinski sign. Okay. So Brudzinski sign, Kernick sign, knuckle rigidity, and Homan sign. These all of the four options are indication of meningitis. So now let's see the rationale. Kernick sign is the inability of the child to extend the legs fully when lying supine. Brudzinski sign is a flexion of hips when the neck is flexed from a supine position. Both of these signs are frequently present in clients with bacterial meningitis. Knuckle rigidity is also present with bacterial meningitis and it occurs when pain prevents the child from touching the chin to the chest. Homan sign is elicited when pain occurs in the calf region when the foot is dorsiflexed. Now let's move on to the question number 2. A home care nurse assesses an older client's functional status and ability to perform activities of daily living. What is the focus area of nurse assessment? Let's see the options. Everyday routines, self-care activities, household management, endurance and flexibility. So in this question, we have been asked that what is the focus when we are assessing functional status. So we have to see functional ability, what he can perform in his daily living. Okay, so the correct option would be self-care activities. Why? Because self-care activity can be done if the person's functional status is intact. So if functional status are intact, then he can do all the functions that are required for self-care, like bathing, toileting, ambulating, brushing teeth, etc. etc. Now let's see the rationale. To evaluate the client's functional status, the nurse assesses the client's ability to perform self-care or activity of daily living. Okay, so functional ability is ability to perform self-care activities like bathing, toileting, ambulating, dressing, and feeding. This is the priority of a client. Okay, so if this has been performed by the client, then his functional ability is intact. Everyday routine, household management, and physical condition are not components of functional status. So other three options are not components of functional status. Only self-care activity is component of self-care functional status. Now let's see question number third. The nurse is assessing a client diagnosed with Addison disease for signs of hyperkalemia. Which sign symptoms should the nurse observe with this electrolyte imbalance? Options are polyuria, cardiac dysrhythmias, dry mucous membrane, prolonged bleeding time. Okay, so in this question we have been mentioned about Addison disease. In Addison disease, there is alteration in aldosterone level. So aldosterone level decreases, which lead to decrease in level of sodium retention of the body. So when aldosterone will be low, body's ability to retain sodium will decrease. So if sodium will decrease in body, there will be signs of hyperkalemia. Now question is asking for the signs of hyperkalemia in the patient. So what would be the answer? The answer would be cardiac dysrhythmias. Why? Because potassium level is very necessary for generation of potential in the cardiac membrane. So if there will be enough potassium and sodium in our body, so cardiac activity will be normal. But if potassium will increase, resting potential will get altered. So this will lead to cardiac dysrhythmias. Now we will see the rationale. The inadequate production of aldosterone in clients with Addison disease cause the inadequate excretion of potassium and result in hyperkalemia. The client manifestations of hyperkalemia are the result of altered nerve transmission. Okay, so when there will be hyperkalemia, there will be alteration in nerve transmission. The most harmful consequence of hyperkalemia is its effect on cardiac function. Based on this information, none of the remaining options are manifestations that are associated with Addison disease or hyperkalemia. I hope the answer is clear. Now let's move on to the next question. The nurse performs an Allen test before blood is drawn from the radial artery for an arterial blood gas assessment. This intervention is done to determine the collateral circulation adequacy of which arterial vessel. Okay, so in this question, we have been asked that when we will do Allen test, what artery we have to assess. For what artery we have to assess the circulatory adequacy. So the options are ulnar artery, carotid artery, brachial artery, or femoral artery. So Allen test is done before ABG analysis. Why it is done? Because we have to check that our flow of blood in hand is intact or not. So before puncturing the radial artery for ABG assessment, we need to assess that if the ulnar artery is intact. Okay. So physician tells the patient to clench his fist and then physician occludes ulnar and radial artery. Now physician will tell the patient to open the fist. The fist will be pale, yellow pale because blood is occluded. Now, if the blood returns within 5 seconds, it means the ulnar artery is intact. Okay, so we have occluded ulnar artery before. Now we have released the pressure. So if the blood flows back to the palm, it means ulnar artery was intact and it has adequate blood flow. But if the palm is pale and blood flow not return normally within 5 seconds and delays, then it means there is some alteration in the blood flow of ulnar artery. So this in Allen test, the artery which is assessed is ulnar artery. So let's read the rationale. Before radial puncture for obtaining an arterial specimen for ABGs, Allen's test is performed to determine adequate ulnar circulation. Failure to assess collateral circulation could result in severe ischemic injury to the hand if damage to the radial artery occur with arterial puncture. Okay, so if we will not assess circulation before ABG analysis, then we can be in risk of ischemia or damage to the hand. Okay, so during puncturing the radial artery, we can see ischemia if ulnar flow is not intact. So it is necessary to do Allen test before ABG analysis. Allen's test does not determine the adequacy of carotid, brachial, or femoral circulation. So only option 1 is correct. Now, let's move on to the next question. A pregnant client diagnosed with diabetes mellitus arrives at the primary healthcare clinic for a follow-up visit. What best assessment should the nurse perform to assess insulin function? Options are urine for specific gravity, for the presence of edema, urine for glucose and ketones, blood pressure, pulse, and respiration. So in this question, we have to find out that what is the best assessment if we have to look for insulin function in the body in a pregnant lady. Okay, so pregnant lady has came to the hospital and we have to assess her insulin function. As you all know that to assess the insulin function, the daily based method is glucose testing. Okay, random blood sugar. But in these four options, random blood sugar test is not given. So we have to find the next best option. So the next best option would be urine for glucose and ketones. Why? Because if there will be hyperglycemia and there will be presence of glucose in the urine, because there will be crossing of renal threshold. So when the renal threshold will be crossed, there will be secretion of glucose in the urine, and there will be ketones body also present in the urine. Other than that, edema cannot tell about insulin function, nor the specific gravity will tell about insulin function, and BP, pulse, and respiration will also not tell about the insulin functioning. Now we will read the rationale. In addition to blood glucose testing, the nurse assessed the pregnant client with diabetes mellitus for glucose and ketones in the urine at each prenatal visit, because the physiological changes of pregnancy can drastically alter insulin requirements. Okay, so when a pregnant lady comes for a visit, we need to see the insulin functioning, because during pregnancy there are some physiological changes that need to be assessed to prevent risk of diabetes mellitus. So it is important to remember though that urine testing for glucose may not be beneficial. Okay, urine testing for glucose is not the best option because of lower renal threshold for glucose. So in pregnancy, the renal threshold is low, which means that if if there is no hyperglycemia, still there will be some glucose in the urine. Okay, so it is not the best indicator of insulin functioning, but there is not given the option of blood glucose level, so we have to check the urine for glucose. Therefore, degree of glycosuria does not accurately reflect the blood glucose level. The assessment of urine for specific gravity, the presence of edema, and BP, pulse, and respirations are more related to clients with gestational hypertension. Okay, so other three options are more related to gestational hypertension. Now let's move on to the next question. A client had arterial blood gases drawn. The results are pH of 7.34, a partial pressure of carbon dioxide of 37 mmHg, a partial pressure of oxygen of 79 mmHg, and bicarbonate level of 19 milliequivalent per liter or 19 millimole per liter. Which disorder should the nurse interpret that the client is experiencing? Okay, so we have to find that what will be the condition if these lab values are given. Okay, so we have to analyze the ABG results. So first we will see pH. Okay, let's explore the options first. So first option is metabolic acidosis, second is metabolic alkalosis, third is respiratory acidosis, and fourth is respiratory alkalosis. So in the question we can see that pH is 7.34, which is acidic, because normal pH is 7.35 to 7.45. So it is acidic. Partial pressure of carbon dioxide is 37 mmHg. Okay, so it is normal. It is in the range of 35 to 45 mmHg. Partial pressure of oxygen of 79 mmHg and bicarbonate level of 19 milliequivalent per liter. So we can see that bicarbonate level is also decreased. So there is proportionality between pH and bicarbonate level. pH is also decreasing and bicarbonate level are also decreasing. It is less than 22 milliequivalent per liter. Normal is 22 to 28. So it is decreased. So we can see that this is a acidic condition. And now we will see bicarbonate. Bicarbonate is related to metabolic functioning. Okay. Carbon dioxide is related to respiratory function and bicarbonate is related to metabolic function. So it means it is condition of metabolic acidosis. Okay. So if there is change in bicarbonate level, it means that it is a metabolic condition. So the answer is metabolic acidosis. Now we will read the rationale. Metabolic acidosis occurs when the pH falls to less than 7.35 and the bicarbonate level falls to less than 22 milliequivalent per liter. With metabolic alkalosis, now we will see what is metabolic alkalosis. pH will rise, okay? So pH will be more than 7.45 and bicarbonate level rise to more than 27 milliequivalent per liter. So if pH rise, bicarbonate level also rise, okay? This is metabolic alkalosis. With respiratory acidosis, pH drops to less than 7.35. It is acidosis, so pH will be less than 7.35. And carbon dioxide level will rise to more than 45. So it is a respiratory condition. In respiratory acidosis, there will be inverse proportion between pH and carbon dioxide. So if pH will decrease, carbon dioxide will increase. And if carbon dioxide will increase, it is respiratory component. So this is respiratory acidosis. Now we will see respiratory alkalosis. So you can interpret that then there will be alkalosis. pH will be more than 7.45 and it is respiratory, which means if pH is increasing, then CO2 will be decreasing. So it will be less than 35 mmHg. I hope the question is clear. Now let's move on to the next question. The nurse caring for a child diagnosed with kidney disease is analyzing the child's laboratory results and notes a sodium level of 148 milliequivalent per liter. On the basis of this finding, which clinical manifestation should the nurse expect to note in the child? First option is lethargy, second is diaphoresis, third is cold wet skin, and fourth is dry sticky mucous membrane. Okay, so in this question, we have to find that what is the feature of hypernatremia. So sodium level is more than 145 milliequivalent per liter. As we know that normal level is 135 to 145. So it is condition of hypernatremia. So if there will be hypernatremia, we can interpret that there will be dehydration in body. More sodium, less water in the body, and it will lead to dehydration. So what can be the signs of dehydration? We can interpret from these options. So answer would be dry sticky mucous membrane. Okay. So when there will be dehydration and increased sodium level, so there will be dry mucous membrane that will be felt sticky. Now we will see the rationale. Hypernatremia occurs when the sodium level is more than 145 milliequivalent per liter. Clinical manifestations include intense thirst. So if there will be increased sodium level, there will be dehydration which lead to thirst, oliguria, which means decrease in urine output, agitation, restlessness, plus skin. So skin will appear reddish, peripheral and pulmonary edema. Increased sodium will lead to water retention in cells. Okay. So this will lead to peripheral edema and pulmonary edema, dry and sticky mucous membrane, nausea and vomiting. So these are all the features of hypernatremia. None of the remaining options are associated with the clinical manifestation of hypernatremia. So lethargy, diaphoresis, cold wet skin are not features of hypernatremia. We can see that these features are if the body fluid level increases. Diaphoresis occur when body fluid level increases. And wet skin also appear in if there will be increase in fluid level. So correct answer is 4. Now let's see the next question. The nurse is caring for an infant admitted to the hospital with a diagnosis of hemolytic disease. Which finding should the nurse expect to note in this infant when reviewing the laboratory results? Options are decreased bilirubin count, elevated blood glucose level, decreased red blood cell count, decreased white blood cell count. So, diagnosis is hemolytic disease. Okay, so we have to focus on the hemolytic disease. In hemolytic disease, what will be the lab values? We can see that in hemolytic disease, RBC, heme means RBC and lysis means breakdown. There will be breakdown of RBC. So eventually when there will be breakdown of RBC, there will be decrease in red blood cell count. It means lab value will show decreased red blood cell count. Now we will see the rationale. The two primary pathophysiological alterations associated with hemolytic diseases are anemia and hyperbilirubinemia. Okay. So when there be hemolytic disease, there will be anemia due to low red blood cells count and hyperbilirubinemia. Why hyperbilirubinemia? Because RBC production is decreased. Okay. And RBC cell production cannot keep pace with the RBC destruction. So the RBC that are forming and RBC that are destroying, there is disbalance. So destruction has been increased, but production is decreased, which will lead to accumulation of RBC. Okay. And liver will not be able to conjugate this much of product. So we can see that in hyperbilirubinemia results from RBC cell destruction that accompanies this disorder and from the normally decreased ability of the neonate liver to conjugate and excrete bilirubin. So when RBC are destroyed, they will form bilirubin. Okay, and bilirubin is not able to excrete efficiently from the liver of neonate. So this will lead to increase in bilirubin level. So we can see that first option is totally incorrect because there will be increase in bilirubin level. Now talking about other options, hypoglycemia is associated with hypertrophy of pancreatic islet cells and increased level of insulin. So blood glucose level is not related to hemolytic disease. It is more related to insulin hypertrophy, pancreatic hypertrophy. The WBC count is not related to this disorder and also WBC count is not related to this disorder. So the correct answer is decrease in RBC count. Now let's see the next question. Intravenous immune globulin therapy is prescribed for a child diagnosed with idiopathic thrombocytopenic purpura. What are the expected results of this medication? So the patient is given IV immunoglobulin, which means that we are inserting direct immunoglobulin inside the body. We are giving direct antibodies in the body. So if we are giving direct antibodies to the body, that what are the expected results of this medication? Now I will tell you that what is idiopathic thrombocytopenic purpura is. So when there is increased destruction of platelets, so there will be low platelet count. Okay. So low platelet count will release in some skin changes, which is known as purpura. There will be bluish discoloration of skin, which is known as idiopathic thrombocytopenic purpura. Now we will see the options. Urine positive for glucose and negative for protein. Urine specific gravity of 1.020 and negative for red blood cells. White blood cells count 18,000 millimeter cube and platelets 3,55,000 mm3. And four option is blood urea nitrogen 22 mg per deciliter and creatinine levels of 2.1 mg per deciliter. So there is decrease in platelet count and we are giving antibodies in the body. So what will be the change we can see? So the correct answer is white blood cell count will be 18,000 mm3 and platelet count will be 3,55,000 mm3. Now let's see the rationale. Intravenous immunoglobulin is usually effective to rapidly increase platelet count. So intravenous immunoglobulin will do what? It will increase platelet count. Okay. It is thought to act by interfering with the attachment of antibody-coated platelets to the receptor on the macrophage cell of the reticuloendothelial system. So what immunoglobulin do? It interferes in attachment of antibody platelets to the macrophages. So when there will be interruption in the attachment of antibody-coated platelet to the macrophages cell, so it will lead to increase in free platelets. Corticosteroid may be prescribed to enhance vascular stability and decrease the production of antiplatelet antibodies. So corticosteroids are also helpful in this disease that will increase the vascular stability and will decrease production of antiplatelet antibodies. So it will also increase platelet level in the body. Based on this information, remaining options are unrelated to the administration of this medication. Now let's see the next question. A child was diagnosed with acute post-streptococcal glomerulonephritis and renal insufficiency. Which laboratory results should the nurse expect to note in the child? Okay, so in this question, so as we can see that question is on glomerulonephritis and renal insufficiency feature. So if there will be damage to the kidney, there will be alteration in the kidney functioning, then what results we can see. Now let's explore the options. Urine positive for glucose and negative for protein. Urine specific gravity of 1.020 and negative for red blood cells. White blood cells count 18,000 mm³ and platelets count 3,55,000 mm³. And blood urea nitrogen 22 mg per deciliter and creatinine levels of 2.1 mg per deciliter. Now, in these options, we have to see that which value is altered and which value is not in the normal range. And also, we have to check that what is the feature of kidney damage. So, let's see the answer. So, the answer is blood urea nitrogen 22 mg per deciliter and creatinine levels of 2.1 mg per deciliter. Now we can see clearly that there is renal insufficiency. So there will be alteration in the kidney function test. Okay. When kidney function test will be altered, so BUN level and creatinine levels will be altered. Now let's see what are the normal value of BUN and creatinine. With post-streptococcal glomerulonephritis, a urine analysis will reveal hematuria with red cell cast. So in this condition, we can see blood in urine and red cell cast. Proteinuria is also present. So protein in urine is also present. If renal insufficiency is severe, the BUN and creatinine levels will be elevated. Okay. So these two values are elevated. And mild anemia is common. Platelet would be lower, whereas glucose is not related. So we can see that glucose is not related to this condition. Platelet level will be decreased. Okay. So in glomerulonephritis, platelet level will decrease. So this is incorrect. Option C is incorrect. And urine specific gravity is also unrelated to glomerulonephritis. So option number 4 is correct. Let's see the next question. A child is admitted to the hospital with a suspected diagnosis of bacterial endocarditis. The child has been experiencing fever, malaise, anorexia, and headache. Which diagnostic study will confirm the diagnosis? Options are a blood culture, a sedimentation rate, a white blood cell count, or electrocardiogram. So, a child was admitted with suspicion of bacterial endocarditis. Okay, so we can see that there is a doubt of bacterial endocarditis. So we have to confirm that what can be the cause of this condition. So if there is infection, so obviously we will have to check that what is causing the infection, which organism is causing the infection. Okay, so we will do blood culture to see the bacteria, that what type of bacteria is causing the endocarditis. So the option is blood culture, which is correct. Now we will see the rationale. The diagnosis of bacterial endocarditis is primarily established on the basis of a positive blood culture of the organism and the visualization of vegetative on echocardiographic studies. So if we have to confirm endocarditis, we will do blood culture to see the growth of organism, and also we can do echocardiograph studies. Other lab tests that may help confirm diagnosis are elevated sedimentation rate and C-reactive protein. So sedimentation rate can be helpful, but it will not confirm the diagnosis. WBC is not related to this disease, and ECG will not help in telling about the bacterial endocarditis. It will only tell about the heart's activity. So answer is blood culture. Now let's see the next question. The nurse interprets that which observation is related to the dysfunction of cranial nerve 3, that is oculomotor nerve. So we have to check in this question, we are going to check that what is the function of oculomotor nerve. From this name, we can see that it is talking about oculo means eye and motor means motor activity. So oculomotor nerve is responsible for motor activity of the eye. So from options, first we will explore the options: mild drowsiness, unilateral ptosis, diminished mental acuity, less frequent spontaneous speech. So what would be the correct answer? Correct answer would be unilateral ptosis. Ptosis means dropping of eyelid. Okay, so there will be no functioning of eyelid, and it will be unilateral, mean in only in one side. So now let's see the rationale. Ptosis of eyelid is caused by pressure on and the dysfunction of cranial nerve 3. Okay, so ptosis of eyelid occur due to pressure and dysfunction of cranial nerve 3, the oculomotor nerve. Remaining options identify early signs of deteriorating level of consciousness. So mild drowsiness, diminished mental acuity, and less frequent spontaneous speech. These are signs of alteration in consciousness level. Now let's see the question number 13. A client diagnosed with a thrombotic stroke experiences period of emotional lability. What should the nurse interpret this behavior as indicating? Okay, so a client who was diagnosed with thrombotic stroke means there is formation of thrombus in the cardiac artery. Okay, so in arteries there is thrombus formation which has lead to thrombotic stroke. Now patient is experiencing emotional lability. What is emotional lability? Emotional lability means there will be sudden mood changes. Patient will show strong emotions. Okay, like he will cry loudly, he will shout, he will show very disturbed mood pattern. So this is emotional lability. So we have to see that what will we interpret from this condition? Is it normal or it is not normal? So options are that the client is not adapting well to the disability, that the problem is likely to get worse before it gets better, that the client is experiencing the usual sequela of stroke, that the client is experiencing the side effects of prescribed anticoagulants. The first option says that client is not adapting to the disability. He is rejecting about his condition and is not able to adapt his condition. Next option says that the problem is going to get worse. If emotional ability is seen, that problem is going to get worse before it gets better. Third option says that experiencing this thing is usual sequel of stroke. So this is normal in this condition. And option 4 says that client is experiencing side effect of anticoagulants. So the correct option is client is experiencing the usual sequela of stroke. So this is normal in the stroke condition. After a thrombotic stroke, the client often experiences periods of emotional lability, which are characterized by sudden bouts of laughing or crying, or by irritability, depression, confusion, or being demanding. So, after experiencing stroke, there will be strong emotional changes. So, it is a normal pattern of this condition. Okay, so this is normal part of clinical picture of client with this health problem. Although it may be difficult for healthcare personnel and family members to deal with it, the other options are incorrect. Okay, so other options are not correct with this condition. Now let's move on to the next question. The nurse is developing a plan of care for a client in buccal extension traction. The nurse should determine that which is a priority client problem. Okay, so in this question, we can see that patient is on a traction, which means patient has fracture. Now, what is buccal traction? It is a kind of traction which is a temporary traction. When patient arrives to hospital, the primary traction which is applied is a buck traction. It is attached to the rope and pulley. Okay, so patient foot is kept on a hard surface with a traction, and there is rope and pulley attached. Okay, so it is a kind of skin traction. Now, what is the priority problem of the client, which a nurse should determine? We have to see that what is the more thing that will be risk in this client. Okay, so the option are immobility, risk of infection, altered independence, insufficient sensory stimulation. Okay, so patient's foot is on traction. So what is the most risk thing? That is, the answer is immobility. Why? Because patient is not able to ambulate. He is on a skin traction. So patient will be fully immobile, which can lead to immobility in the client. The priority client problem in buck traction is immobility. Option 3 and 4 may also be appropriate for client in traction, but immobility presents the greatest risk for the development of complications. Okay, so altered independence and insufficient sensory stimulation, these are also correct options, but the priority would be given to immobility. Buck traction is a skin traction and there are rope inside. Okay, so it is a skin traction with a rope and pulley. Now let's see the next question. A pregnant client diagnosed with mitral valve prolapse is prescribed anticoagulant therapy during pregnancy. The nurse reviews the client's medical record, expecting to note that which medication therapy is prescribed daily. Now, in this question, we have to tell that what is the medication we will give to a pregnant lady if she is having anticoagulant. Okay, so mitral valve prolapse means mitral valves are not intact and they are flapped. Okay, so they are not working properly. So in this condition, there can be clotting of blood. So we have to give anticoagulant. So what anticoagulant is safe in pregnancy? We have to check from these options. Option 1 is oral warfarin. Option 2, intravenous infusion of heparin sodium. Option 3, subcutaneous administration of terbutaline. Option 4, subcutaneous administration of heparin sodium. So in this question, we have been focusing on that it is a condition of pregnancy. Now, in pregnancy, when we are giving any kind of medication, we have to remember that it should be safe for the fetus, which should not cross the placenta. Now, warfarin crosses the placenta, so it is unsafe to give. Now, talking about IV infusion of heparin sodium. So infusion cannot be given to the pregnant lady because infusion is only given if the amount of drug is large. Okay, so it is also not a correct option. Subcutaneous administration of terbutaline. Okay, so terbutaline is given in management of preterm labor. So it is not related to anticoagulant. So option 4, that is subcutaneous administration of heparin sodium. This is correct option. So heparin is a drug which will not cross the placenta and we will give it subcutaneously, which will be safe for administration. So the correct answer is subcutaneous administration of heparin sodium. Pregnant women with mitral valve prolapse are frequently given anticoagulant therapy during pregnancy because they are at greater risk of thromboembolic disease during the antenatal, intrapartum, and postpartum period. Heparin, which is not past the placental barrier, is safe anticoagulant therapy during pregnancy and it would be administered by the subcutaneous route. So we can see that a pregnant lady, when she is at risk of thromboembolic disease, so anticoagulant is given and the safest is heparin because it does not cross the placenta. Okay. And warfarin is contraindicated during pregnancy because it passes the placental barrier and cause potential fetal malformation and hemorrhagic disorders. Okay, so warfarin can cause fetal malformations and hemorrhagic disorders. Okay, like hemophilia. Terbutaline is a medication that is indicated for preterm labor management. Okay, so the correct answer would be heparin subcutaneously. Now let's see the next question. At the last vaginal examination, the client who is in the last first stage of labor was fully effaced. Fully effacement means that the vagina is fully dilated. Okay. 8 centimeter dilated, vertex presentation, and station -1. This observation would indicate that the fetus was in fetal distress. Okay, so we have to tell that what are the features of fetal distress among these 4 options. The fetal heart rate slowly drops to 110 beats per minute during strong contractions, recovering to 138 beats per minute immediately afterwards. So, fetal heart rate drop during the strong contractions and recover immediately. This is the sign of fetal distress. So, we can check the next option. Fresh meconium is found on the examiner's gloved finger. Okay, so fresh meconium is appearing from the vagina. Okay, and the fetal monitor pattern remains essentially unchanged. Okay, the fetal monitor patterns are unchanged, which means that there is no alteration in the heartbeat of the fetus. Fresh thick meconium is passed with a small gush of liquid, and the fetal monitor shows the late decelerations with a variable descending baseline. Now, in this option, we can see that there is passage of fresh thick meconium, and fetal heart rate is decreasing and is altered and is not recovering. Okay, so this option is on our focus. This can be the correct options. Now, fourth option, the vaginal exam continues to reveal some old meconium stain. So, in this condition, there is some old meconium staining, and fetal monitor demonstrates U-shaped pattern. U-shaped pattern means that fetal rate is dropping suddenly, then increasing suddenly during contractions, recovering to baseline of 140 beats per minute. So we can see that in option 1, 2, and 4, fetal monitor rate is recovering to normal. But in option number 3, that there is shown decelerations with variable descending baseline. Okay, so baseline data is descending and is abnormal. So the answer is option number 3. Now we will see the rationale. Meconium staining alone is not a sign of fetal distress. Okay, so meconium is very normal if it is present from the vagina during vaginal examination. Okay, so meconium passage is normal physiological function that is frequently noted for a fetus with a fetus of more than 38 weeks of gestation. Fresh meconium in combination with late decelerations and variable descending baseline is an ominous sign. Ominous sign means it is a fatal dangerous sign of fetal distress caused by fetal hypoxia. Okay, so if there will be fetal hypoxia, there will be decreased oxygen level for fetus, so there will be decrease in the baseline data in the fetal monitor. So the meconium is not a component of fetal distress. If there will be decrease in fetal heart rate, it is the main component of fetal distress. Fetal heart rate to drop than less than 140 to 160 beats per minute range in late labor during contractions, and in healthy fetus, the fetal rate will be recovered between contractions. Okay, so if the fetal rate is recovering, then it is normal in the healthy fetus, and it is not a sign of fetal distress. In option 4, we read that old meconium staining may be result of prenatal trauma. Okay, so if we will find any old stain, then it may be indicated that there was any trauma during the antenatal period and which has been resolved now. So stain is coming out of the vagina during delivery. Now see the next question. A child diagnosed with seizures is being treated with carbamazepine. The nurse reviews the laboratory reports of the result of the drug plasma level and determines that the plasma level is in a therapeutic range if which is noted. Okay, so in this question, we have to tell that what is the normal range of carbamazepine. So the options are 1 mcg per ml, option 2, 10 mcg per ml, option 3, 18 mcg per ml, option 4, 20 mcg per ml. So the correct answer is 10 mcg per ml. When carbamazepine is administered, plasma levels of the medication need to be monitored periodically to check for the client's absorption of medication daily. Okay, so client is having seizure, so we have to give anticonvulsant. So if we are giving anticonvulsant, we have to check its level in the body. Now, the normal level is 5 to 12 mcg per ml. This is the normal range. So 5 to 12 mg per deciliter is the normal range. So correct answer is 10 mcg per ml. Option 1 indicates low levels that possibly necessitates an increased medication dose. Okay, so 1 mcg is very less amount, so we have to increase dose. Okay, and in 18 mcg and 20 mcg, it means that it is very high dose and we need to stop this medication. So this is the correct dosage. 10 mcg per ml is correct dosage. Now next question. The nurse performs an assessment on a client with a history of heart failure who has been taking diuretics on a long-term basis. Okay. The nurse reviews the medication record knowing that which medication is, if prescribed for this client, would place the client at risk of hypokalemia. Okay. So patient was having diuretic on a long term. Okay. So now we have to check that what could be the risk of hypokalemia. But what drug can lead to hypokalemia? So diuretic is of two types, that is potassium retaining diuretic and potassium losing diuretic. Potassium losing diuretic will lose potassium from our body. This will lead to hypokalemia. So we have to check that from these options which one is potassium losing diuretic. First option is bumetanide, second is trimethoprim, third is spironolactone, and fourth is hydrochlorothiazide. Now the correct answer is bumetanide because trimethoprim, spironolactone, and hydrochlorothiazide, these three are potassium retaining diuretic. It means they help in retaining of potassium in our body and will not lead to hypokalemia. So the drug that will cause risk of hypokalemia is bumetanide. So bumetanide is a loop diuretic. The client on this medication would be at risk of hypokalemia. Trimethoprim, spironolactone, and hydrochlorothiazide are potassium retaining diuretic. Now we will move on to the next question. The home care nurse is preparing to visit a client diagnosed with mania disease. The nurse reviews the primary healthcare provider's prescriptions and expects to educate the client on which dietary measures. So in this question, we have been told about the mania disease. Okay, in mania disease, it will occur when there will be increase in pressure inside the fluid. So in mania disease, when in endolymphatic fluid increase or the pressure in air increase, it leads to hearing loss. Okay, hearing loss, tinnitus, vertigo. This can happen in mania disease. So what we have to focus while giving dietary advice to the patient. So we have to keep in mind that we will not lead to increase in pressure in the ear and we will minimize the endolymphatic fluid in the ear. So options are a low fiber diet with decreased fluid, a low sodium diet in food restriction, a low fat diet with a restriction of citrus fruits, a low carbohydrate diet, and elimination of red meat. So from these options, we can clearly see that to cure this condition and to minimize the degree of this condition, we have to provide low sodium diet and we have to restrict fluid. Now we will see the rationale. Dietary changes such as salt and fluid restrictions that reduce the amount of endolymphatic fluid are sometimes prescribed for clients with mania disease. Okay, so when we will give less sodium, so there will be less sodium retention in body and there will be less water retention in the body cells. So if there will be less water retention, it will lead to decrease in the pressure in the ear and decrease in fluid level in the ear, which can be helpful to cure the disease. None of the remaining options are prescribed for this disorder. So other options does not help in this disorder. Now let's see the next question. The nurse is caring for a client who has been diagnosed with tuberculosis. The client is receiving 600 mg of oral rifampicin daily. Which laboratory finding would indicate to the nurse that the client is experiencing an adverse effect? So in this question, we have to tell that what can be the adverse effect of rifampicin. 600 mg of rifampicin can be harmful if given in large doses. So what can be the adverse effect? A sedimentation rate of 15 mm per hour, a white blood cell count of 6000 mmQ, a total bilirubin level of 0.3 mg per deciliter, alanine aminotransferase of 80 units per deciliter. Okay, so we are giving rifampicin. So the major organ that will get affected would be liver. Why? Because liver is responsible for detoxification in our body, and it is responsible for metabolism all of the drugs we take. Okay, so if we will give excess of this drug, so liver will be affected most. So the answer would be alanine aminotransferase of 80 unit per deciliter. Why? Because ELT is a hormone of liver. So if liver will get altered, liver will get affected. So hormone levels will also get altered. So this is the correct option. Now we will see the rationale. So adverse or toxic effects of rifampicin include hepatotoxicity. So the first toxic effect we will see toxicity in the liver, because in excessive dose it will lead to alteration in the liver. Hepatitis, that is inflammation of liver, jaundice, blood dyscrasis. Blood dyscrasis is a condition in which there are alteration in blood. Okay, so there can be bone marrow depression, there can be decrease in platelet count, there can be decrease in RBC count. So conditions of blood that are abnormal are called blood dyscrasias. Stevens-Johnson syndrome. In Stevens-Johnson syndrome, this is seen if there is affected liver. So in this condition, there are some skin changes that are very dangerous in looks. Like they will be like red big spots on the skin that are fatal. And antibiotic related colitis. Okay, so rifampicin as antibiotic, so this can also inflame the colon. The nurse monitors for increased liver function, bilirubin, blood urine nitrogen, and uric acid levels, because elevation indicated adverse effect. The normal ALT level is 4 to 36 units per liter. The normal total bilirubin level is 0.3 to 1 mg per deciliter. Okay, so normal ALT level is 4 to 36, and this is elevated very much. This is more than 36. So it means the liver has been affected. The normal sedimentation rate is 0 to 30 mm per hour, and normal white blood cell count is 5,000 to 10,000 mm cube. So WBC count is normal, sedimentation is also normal, and total bilirubin count is also normal. Only ALT is abnormal. So this is the correct answer. Now let's see the next question. A home care nurse is assessing a client who is prescribed prazosin. Which statement by the client would support the need for further teaching regarding medication compliance? Okay, so patient is having prazosin. Prazosin is antihypertensive drug. It is given to the patient with high BP. So now we are assessing the client that what teaching he will need if which of the following of the sentence he say. Okay, so from the following options we can analyze that further teaching is needed for the client. First is if I feel dizzy, I'll skip my dose for a few days. So if patient says that if I will feel dizzy, I'll skip my dose. So this statement needs further teaching or not? Now next option is I can't see the numbers on the label to know how much salt is in the food. Patient is not able to correctly see the label and the thing written on that. So this needs a further teaching. Or I understand why I have to keep taking pills even when my BP is normal. If this statement needs further teaching, or if I have a cold, I shouldn't take any over-the-counter remedies without consulting my doctor. So from these options, we have to check that from these sentences, if patient says one of the sentence, then he needs further teaching. So the answer is, if I feel dizzy, I'll skip my dose for a few days. Okay, so it is dangerous. So if patient says so, then he needs further teaching, and we need to further teach him more about his condition and advise more about his daily routine things. So prazosin is used to treat hypertension. The side effects of prazosin are dizziness and impotence. The client needs to be instructed to call the primary healthcare provider if these side effects occur. Holding, skipping medication will cause an abrupt rise in BP. Option 2 is indicates difficulty taking care of oneself. So option 2 do not need further teaching because his patient is just telling about that he is having difficulty in something. In option 3, we can see that he has good knowledge about his condition because he is saying that he will take this even if his BP is normal. Okay, because if we will stop the medicine, there can be abrupt increase in BP. Okay, so this is normal. Okay, if I have cold, I shouldn't take any over the counter remedies. This is also correct. We should not take any over the counter medicine. So teaching will need if patient say that he will skip the dose. Now next question. A client manages peptic ulcer disease with excessive amount of oral antacid. Signs, symptoms of which acid-base imbalance should the nurse assess for? So the client is having excessive amount of antacid because he has peptic ulcer disease. So when there is peptic ulcer disease, we have to neutralize the acidity in the gut to not increase the severity of ulcer. So if patient is having excessive antacid, which means that gut is going to be more alkaline. Now, which of the following condition we will see? Metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. So antacid will lead to alkalosis. So alkalosis would be the correct answer. Now we can see metabolic or respiratory. So it will be metabolic because it is a condition of gut. Now let's see the rationale. Oral antacids can be effective treatment for peptic ulcer disease when administered properly. But when they are taken in excess, they can lead to metabolic alkalosis, that is pH of more than 7.45 and a bicarbonate ion HCO3 level of more than 27 milliequivalent per liter. As effective therapy of peptic ulcer disease, antacids bind with the hydrochloric acid. So HCl is the acid that is produced in our gut. So what do antacids do? It bind to the HCl of gastric secretions and halt the corrosive action of HCl. So it halts the mechanism of HCl and it will not cause corrosion of the ulcer. However, antacids are alkaline substance. Excessive administration can exceed the kidney's ability to clear the excess HCO3. So if we will take excessive antacid, then kidney will not able to clear excessive HCO3, which will lead to increase of HCO3 and increase in pH. So when pH is increased, HCO3 is increased, it means there will be alkalosis and there will be metabolic component. So will lead to metabolic alkalosis. Metabolic acidosis occur when pH is low. Okay, so when pH is less than 7.35, it will be acidosis and HCO3 will also be low because these both components are proportional to each other. If pH will be low, HCO3 will be also low. Respiratory acidosis occurs when the pH is low and the partial pressure of carbon dioxide is high. And respiratory alkalosis occur when pH is high and PCO2 is low. We have done this question earlier, so I will not explain this. Now let's move to the next question. The nurse is assessing a 39-year-old Caucasian client with blood pressure of 152 by 92 mmHg at rest, a total cholesterol of 180 mg per deciliter and a fasting blood glucose level of 90 mg per deciliter. On which risk factor for coronary artery disease should the nurse place priority? Options are age, hypertension, hyperlipidemia, and glucose intolerance. So we have given these factors. So we have to find that which is a risk factor. Age is a risk factor, BP is risk factor, cholesterol level is risk factor, or glucose level is risk factor. So we can see that glucose level is in normal range. Also, cholesterol level is also in normal range. It is less than 200 mg per deciliter. So it is in normal range. Now, we can see that patient is 39-year-old, means if the patient is less than 40 years of age, then this is a modifiable. So it is not a risk factor, okay? Because it can be modified, okay? So coronary artery disease can be modified if age is less than 39-year-old. Now we will see the BP component. BP is 142 by 92 mmHg, which means BP is increased. So the correct answer would be hypertension. Now we will see the rationale. Hypertension, cigarette smoking, and hyperlipidemia are major risk modifiable factors for coronary artery disease. Glucose intolerance, obesity, and response to stress are also contributing factors. An age of more than 40 years is a non-modifiable risk factor. So, 39 years is not at risk. A cholesterol level of 180 mg per deciliter and blood glucose level of 90 mg per deciliter are in normal range. The nurse places priority on a major risk factors that need modification. Okay, so high BP need to be modified. So we need to put this as a major risk factor for coronary artery disease. Now let's move on to the next question. What is the nurse priority for the post-procedure care of a client who has just returned to the unit after scheduled intravenous pyelogram? Options are maintaining the client on bed rest, ambulating the client in hallway, encouraging the increased intake of oral fluids, encouraging the client to try to void frequently. Okay, so the patient has come returned from intravenous pyelogram. So intravenous pyelogram means that there is examination of urinary tract. Okay, so there is examination of urinary tract by inserting contrast dye. So we will examine the urinary tract by inserting a contrast dye, from which we can see if there is any obstruction or any malformation in the urinary tract. So when we put a contrast dye in a patient, we have to keep in mind that we need to excrete and remove that contrast dye after the procedure. So to remove that excess contrast dye from our body, we need to provide excessive fluid. Okay, so we have to increase the oral fluid intake. So the answer would be encouraging the increased intake of oral fluid. Now let's see the rationale. After IVP, the client should take in increased fluids to aid in the clearance of the dye used for procedure. The client is usually allowed activity as tolerated without any specific activity guidelines. So it is unnecessary to void frequently after the procedure. So after the procedure, frequently voiding is unnecessary. It is not a need. And ambulating is not a advice that we have to give, because patient can easily ambulate after the procedure. And bed rest should not be advised. Patient can move. Okay. So the answer would be increase intake of fluids to remove the contrast dye from the patient's kidney. Okay. So next question. A client diagnosed with myasthenia gravis is reporting vomiting, abdominal cramps, diarrhea. The nurse notes that the client is hypotensive and experiencing facial muscle twitching. Which possible situation does this assessment data support? Options are myasthenic crisis, cholinergic crisis, systematic infection, reaction to plasmapheresis. So patient is having myasthenia gravis. Okay. So in myasthenia gravis, we provide anticholinergic drugs. Okay. So we provide anticholinesterase drug like neostigmine. Okay. So when we provide neostigmine to the client, we can see that patient is having vomiting, abdominal cramps, and diarrhea. Okay. Hypotension and facial muscle twitching. So we can see that the answer could be cholinergic crisis, because we have been giving medication that can lead to overdose and that can lead to further symptoms. Now we will see the rationale. Signs and symptoms of cholinergic crisis include nausea, vomiting, abdominal cramping, diarrhea, blurred vision, pallor, facial muscle twitching, pupillary miosis, and hypotension. It is observed by over medication with cholinergic, that is anticholinesterase medication, and it is treated by withholding medication. So these symptoms we can see if patient is having overdose of anticholinesterase drug. Okay, and we will see in myasthenia crisis which occur due to under medication of anticholinesterase. So myasthenia crisis means there will be weakness of voluntary muscles due to not proper use of drugs of myasthenia gravis. So myasthenia crisis is an exacerbation of myasthenic symptoms caused by under-medication with anticholinergic medication. There are no data in this question to support the remaining options. So this systematic infection and reaction to plasmapheresis is not related to this disease. Next question. The nurse is assigned to care for a child diagnosed with juvenile idiopathic arthritis. What is the child's priority problem? Acute pain, potential difficulty with everyday tasks, impaired mobility causing potential injury, negative view of body because of activity intolerance. Okay, so in this question, we can see that a child is having arthritis, that is juvenile idiopathic arthritis. So there is inflammation of joint, so obviously there will be pain. Okay, so child's first priority would be acute pain. Why? Because these three options can be managed afterwards, but the first thing we have to manage is pain, because if there will be more pain, patient will be not able to do the daily activity and will not live peacefully. So first we need to explicit the pain. All of the problems identified in the options are appropriate for the child with IAA. However, acute pain must be managed before other problems can be addressed. So we have to first manage acute pain to relieve the symptoms of pain. Next question. A child is admitted to the hospital with a suspected diagnosis of idiopathic thrombocytopenic purpura, and diagnostic studies are performed. Which diagnostic results is indicated of this disorder? So I have already mentioned that thrombocytopenic purpura is decrease in platelet level in the body, which lead to skin changes. So if there is decrease in platelet level in the body, what we can see? First option is an elevated platelet count. This is incorrect. Elevated hemoglobin and hematocrit level. Bone marrow exam showing increased megakaryocytes. Bone marrow exam indicated increase in mature white blood cells. So as I mentioned that there will be decrease in platelet count, which means that there is some alteration in body, which is leading to decrease in platelet level count. So we have to see that what are the things that can lead to decrease in platelet count. So hemoglobin and hematocrit level is not related to this disease. Now in the option C, we can see that there is increased megakaryocytes. Megakaryocytes are precursor of platelets. These lead to formation of platelets. So if there is increase in megakaryocytes, obviously, if there is alteration in megakaryocytes, so there will be alteration in platelet count. So the correct answer is bone marrow exam showing increased megakaryocyte. Now let's see the rationale. The laboratory manifestations of ITP include the presence of low platelet count of usually less than 2000 millimeter cube. Thrombocytopenia is the only laboratory abnormality expected with ITP. So there will be not related to hemoglobin, not related to bone marrow. Okay, so it will be related to only platelet count. If there has been significant blood loss, there is evidence of anemia in the blood cell count. If bone marrow examination is performed, the results with ITP show a normal or increased number of megakaryocytes, which are the precursor of platelets. So, if there is increase in number of megakaryocytes, so ITP will be abnormal. So, option 3 is correct. Now, let's see question. The mother explains that after meals, her infant has been vomiting and now it is becoming more frequent and forceful. During the assessment, the nurse notes visible peristaltic veil movements from left to right across the infant's abdomen. On the basis of these findings, which condition should the nurse suspect? Colic, intussusception, congenital megacolon, hypertrophic pyloric stenosis. So the features given in these options are, in this question is vomiting and peristaltic wave from left to right. So peristaltic wave from left to right is feature of hypertrophic pyloric stenosis. Okay. So if there is presence of peristaltic wave, it means there is hypertrophic pyloric stenosis. Opposite to it, in intussusception, there is no peristaltic wave, and in congenital megacolon, there is no peristaltic wave, because in both these conditions, there is obstruction in the normal gut pathway. So there will be no peristaltic movement. So we can easily interpret that if there is left to right peristaltic movement, it will indicate hypertrophic pyloric stenosis. Colic is related to pain. Okay. Now let's see the rationale. In pyloric stenosis, the vomitus contains sore, undigested food, but no bile. Okay. So in pyloric stenosis, there will be no bile in the vomiting. The child is constipated and visible peristaltic waves move from left to right. It is a very particular feature of this condition. So left to right peristaltic movement, and there will be a movable, palpable, firm olive shaped mass in the right upper quadrant. Okay, so in patient with pyloric stenosis, there will be mass that will be olive shaped, okay, which will be palpable. So peristaltic movement, palpable olive mass, and vomiting without bile is feature of pyloric stenosis. Crying during the evening hours appearing to be in pain. So mean it is pain which is related to colic. So crying during evening hour pain, but eating well and gaining weight are features of colic. An infant who suddenly becomes pale, cries out, and draws the legs up to the chest is demonstrated physical sign of interception. So in interception, there is obstruction of colon, so patient will draws his legs upon the chest to relieve the symptom. He will cry and will become pale. Ribbon-like stool, bile-stained emesis, and absence of peristalsis and abdominal distension. These are symptoms of congenital megacolon, which is Hirschsprung's disease. Now let's move on to the next question. The nurse is reviewing the laboratory analysis of CSF obtained during lumbar puncture from a child who is suspected of having bacterial meningitis. Which result would most likely confirm this diagnosis? So patient is having bacterial meningitis. We are obtaining lumbar punctures from lumbar puncture. We are obtaining CSF. Now we have to tell that what are the feature of CSF in meningitis. Clear CSF with low protein and low glucose. Cloudy CSF with low protein and low glucose. Cloudy CSF with high protein and low glucose. Decreased pressure and cloudy CSF with high protein. So, in bacterial meningitis, we can see that pressure will increase in CSF and bacteria is present, so protein will also increase. So, correct answer is cloudy CSF with high protein and low glucose. Okay, so option fourth is incorrect because pressure increase in meningitis. Okay, option 1 and 2 are also incorrect because they are claiming low protein, but protein level should be high. So option C is correct. A diagnosis of meningitis is made by testing CSF obtained by lumbar puncture. In the case of bacterial meningitis, findings usually include increased pressure and cloudy CSF with high protein and low glucose. Therefore, options 1 to 4 are incorrect. Last question. A child is admitted to the pediatric unit with a diagnosis of acute gastroenteritis. The nurse monitors the child for signs of hypovolemic shock as a result of fluid and electrolyte losses that have occurred in the child. Which finding would indicate the presence of compensated shock? So in this question, we have given that child is having sign of hypovolemic shock. Hypovolemia means there is decreased level of fluid in the body. So we have to tell the sign of dehydration and hypovolemia. So options are bradycardia, hypotension, profuse diarrhea, capillary refill time greater than 2 seconds. As we all know that in hypovolemia, when there is decreased fluid level in blood, so heart will try to increase the circulation. Heart will compensate and provide more and more circulation to the extremities. So this will lead to tachycardia. So option 1 is incorrect. When the heart load will increase, BP will also increase. So hypotension is also incorrect. Bradycardia and hypotension are incorrect. Profuse diarrhea. Profuse diarrhea is sign of hypervolemia. Diarrhea occurs when there is increased fluid level. So correct answer is capillary refill time greater than 2 seconds. So this is a sign of shock. When capillary refill time, which means that when we pinch our finger, there is collection of blood in the tip, and when we will release the finger, so there will refilling of blood in the capillary. So if it will delay, then it will delay a sign of shock. So the rationale is shock may be classified as compensated or decompensated. In compensated shock, the child becomes tachycardic in effort to increase the cardiac output. The blood pressure remains normal. Okay, so blood pressure does not increase, it remains normal. The capillary refill time may be prolonged and more than 2 seconds, and the child may become irritable as a result of increase in hypoxia. Okay, so the most prevalent cause of hypovolemic shock is fluid and electrolyte losses associated with gastroenteritis. Diarrhea is not a sign of shock, rather it is a cause of fluid and electrolyte imbalance. So diarrhea will occur if there will be fluid and electrolyte imbalance. It is not a sign of shock, and these two are also not a sign of shock. So the answer is 4. This was all about this session. We have solved 30 questions. I hope this helped you. Thank you.